So it's my pleasure to introduce today's speaker, Dr. Sunita Puri. Dr. Puri is a member of the Palliative Care Division in the Department of Medicine here at UMass Chan. Dr. Puri received her BA from Yale University with distinction. She picked up a couple of master's degrees before getting her MD degree from the University of California at Berkeley in San Francisco. She did her internship at UCSF in San Francisco, as well as her residency, and then did a clinical fellowship in hospice and palliative medicine at Stanford University. She's a much sought after speaker, and she has written a very popular book called That Good Night, Life and Medicine in the 11th Hour, which was published in March of 2019 by Viking and Penguin Random House Press. And she's made a number of appearances in the media. It's probably too many to name, but I'll name a few, including the PBS Amanpour Show, Texas Public Radio, Boston NPR, WNYC, and a number of other publications, including The Atlantic. So I highly recommend that book to you. She's currently an associate professor of medicine and program director of the Hospice and Palliative Medicine Fellowship here at UMass. And she's going to be talking, I think, about some of the topics in your book. Is that right? Or some. Okay. All right. All right. The title of her talk is Palliative Medicine Perspectives on Discussions of Suffering, Goals of Care, and Life's Ends with Patients with Mental Illness. Dr. Puri.
Hi, everybody. Can you hear me okay? The mic's working? Excellent. I'm not quite sure where to look for the folks on Zoom. Is it just right back there? I hope I'm looking at you guys on Zoom. If I'm not, someone just type it in the chat and let me know where to look. It's really nice to be with you here today. The title of my talk is The Words We Use and Why They Matter, Palliative Medicine Perspectives on Discussions of Suffering, Goals of Care, and Life's End for Patients with Mental Illness. This is me and my brother. I just want to say I have no financial disclosures or conflicts of interest to declare, but my brother is a psychiatrist, and he's actually both a child and adolescent and an addiction psychiatrist. So I think palliative care and psychiatry have so much in common, including some humorous things. And I just wanted to say at the outset that I have a lot of respect for what all of you do, because I know it's an incredibly challenging job. So the objectives I have today are to define palliative medicine and indications for consultation, to understand the intersection between palliative medicine and psychiatric practice for people with serious illness, to understand and describe the different types of goals of care conversations that exist, and to offer you some practical approaches to communication when we're talking with people who are seriously ill and also who have serious mental illness. So how many of you, in all honesty, have sometimes wondered what palliative medicine is? All right, good. No, I'm glad that you're, being honest about that. This is a safe space, and by the end, you're going to be able to define it very precisely. So in 1980, the World Health Organization put out this definition of palliative medicine, which is that it's an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. So what does that actually translate into? Palliative medicine is an interdisciplinary team, and we need that team to attend to each of the domains of suffering that we call total pain. So total pain is not just the physical pain that somebody with cancer might have and that we treat. There's the emotional, existential, and spiritual components to pain that patients and their families experience. And it's that totality that we attend to, which is why we need not just doctors, but nurses, social workers, and spiritual care providers. And here we also have a music therapist. We need all those disciplines to interact and bring their unique lenses to the patient and family before us to really attend successfully to total pain. An important thing to know is that people can get palliative medicine right alongside other therapies, be it chemotherapy or dialysis or advanced heart failure therapies. So there isn't a choice to be made between therapies directed at disease and palliative care. Those two things can and should coexist. You can have palliative medicine involved for any diagnosis at any age or stage of disease, even diseases that we think are going to be curative, like a bone marrow transplant. We collaborate closely with other teams, so the primary teams, but also the other consulting teams. And you're most likely to find palliative medicine in the inpatient setting, just generally, but there's a growing number of community-based and clinic-based programs and home-based services as well. To give you a brief one citation of the impact of palliative medicine, when we are involved from the beginning for patients with metastatic non-small cell lung cancer, Jennifer Temmel and her group at Mass General did this study, which was kind of the first big RCT for palliative medicine. They randomized half of 151 patients to just getting standard oncologic care and PRN palliative care as needed. The intervention group got standard oncologic treatment and palliative medicine from the time of diagnosis. And what the study showed was that the patients getting both lived an average of 12 weeks longer, but more importantly, lived better. And quality of life assessments were far better in the intervention group than in the control group. I like this model. There are others, but this is a kind of nice, straightforward model of the relationship between palliative medicine and other medical care. So from the time of diagnosis, when we are giving people life-prolonging or disease-directed treatment, if we are involved, you'll see that as time goes on, the ratio of disease-focused treatment changes and the palliative medicine interventions increase. And ultimately, life-prolonging care or disease-focused treatment gets discontinued when people transition to hospice, which is a type of palliative care provided to people who prognostically are in the last 6 months of life. So this integration is so, so important. And this diagram actually comes from the American Heart Association. The impact of palliative care consultation is significant. When you change treatment plans to align with patients' goals and preferences, you end up often reducing costly interventions. People who understand what's going on with them more clearly may not want to go to the ICU. We really help with symptom-focused treatments in all of those domains, which makes people feel better. And we prevent interventions that they wouldn't want. Best practices, so early palliative care consultation has been recommended by the American Society of Clinical Oncology, the American Heart Association, and a number of kidney societies. So across the board, in some of the specialties where there are big, often painful and challenging interventions that are offered, all of them recommend that from the time of diagnosis, palliative medicine should be involved, whether it's advanced heart failure or someone renal failure considering dialysis, or somebody like in the Temmel study at getting a diagnosis of metastatic cancer and going down that particular journey. So there are some criteria that are recommended or things to think about for palliative medicine consults in the inpatient setting. I really like this one. So the surprise question: if you think about the patient before you in a year from now, if you wouldn't be surprised if they died, that's a reason to consider a palliative care consultation if there's a specific consult question in the inpatient setting or a referral to outpatient setting. Some of these other criteria are at different medical centers more disputed or accepted, but I also think anybody awaiting or deemed ineligible for a solid organ or liquid transplant, people who are going to get LVADs, we actually have to see according to CMS. And then obviously, if there's goals of care clarification, any type of those domains of total pain, request for service. And I think, if somebody's going to an LTAC, generally they're probably not thriving. And so pending discharge to an LTAC is another thing to consider. I think of hospice as a type of palliative care, as I mentioned, provided to people in the last 6 months of life. So you still get that interdisciplinary team care that's often provided at home or in a nursing home, very rarely in facilities like Rose Monahan. We're very lucky to have a facility like that. And I'm going to go through very briefly some of what hospice is. It's 100% benefit, totally covered under Medicare and many insurances. Medicare is the largest payer for hospice services. And the hospice benefit was actually established by Ronald Reagan in 1982, and Bill Clinton in 1993 made some additional legislation mandating that all insurance companies actually cover hospice services. So most patients should not have to pay for it. There are some instances in which people do have to. So to turn a bit to our discipline, so we share many things in common, right? We care for people with chronic, often incurable illnesses, and we really use the biopsychosocial model of care. So the focus on the whole person and all of their domains of life. Psychiatry and palliative care often confront serious ethical issues in the care of our patients, and we rely on a multidisciplinary team. There's also an overlap in skill set. So we're managing symptoms, attending to quality of life. We're providing support for patients in their mental health care planning. We do a lot of that in terms of advanced care planning. We're assessing caregiver and family needs and referring people to specialty services as needed. And a survey in the Journal of Pain and Symptom Management actually found that only 10% of palliative care teams actively include psychiatry. There are a lot more psychiatrists doing palliative care training now, but 71% of the people who were surveyed here, which were all palliative medicine practitioners, wanted a psychiatrist on their team. We also share some humorous overlap. I just thought I would help people I know this is a very light topic I'm going to be talking about, but how many of you have had the following consultation questions? The patient is crying. And you're like, what is your consult question? The patient is refusing dialysis. We're worried that this is suicidal ideation. Can you see him? We need help with a capacity evaluation. I know that's everyone's favorite consult question in this audience. So I think there's a certain amount of just misunderstanding of what our specialties do that's fairly common in the places that I've worked and trained. And so we also have that as part of the reason we're comrades. So people with serious mental illness suffer a lot of healthcare disparities, especially when it comes to getting diagnosed on time and getting the treatment they need. So about 4% of our population has serious mental illness in the form of schizophrenia, bipolar, severe major depressive disorder being amongst the most common. And they a lot of the times have later diagnoses of chronic illnesses. So they're at 2 to 3 times the risk for diabetes, 5 times the risk compared to the general population for metabolic syndrome, sometimes because of the meds we need to give them. Their mortality ratios are 3.6 for cardiovascular disease, 2.4 for cancer, and 9.9 for COPD. So significantly elevated risk, not only for developing these diseases, but dying early from them. So on average, some of these patients have a 15 to 25 year shorter lifespan than controls, and their access to palliative care is about a quarter of what it is for the general population. And I think there's patient, clinician, and system level factors that contribute to this disparity: decreased access to palliative care, uneven continued engagement with mental health services, and low rates of advanced care planning. For the sake of time, I'm going to very quickly summarize these two studies, one of which was done in Manitoba, the first one, which showed that patients with schizophrenia are 2 to 4 times less likely to get access to palliative care, 30% less likely to get adequate pain relief, and significantly less access to mental health providers, with more likelihood of dying in nursing homes. Similar findings to this study were found in Australia and New Zealand. And in the UK, they looked at the same sort of issue of access to mental health or to palliative care services if you have mental health issues. And their recommendations were that there needs to be a patient advocate involved for this particular population to coordinate care and ensure that people are getting access to the care they need, to create fewer barriers and improved communication between the teams caring for patients, to educate and support and supervise the staff, and to proactively make sure people are getting access to physical health care, primary care, to prevent delays in diagnosis. Palliative care and psychiatry also have a lot of overlap when it comes to emotional and existential suffering. So Dame Cecily Saunders, who's kind of considered the founder of modern hospice, had said that mental distress may perhaps be the most intractable pain of all. And a meta-analysis for patients with cancer showed that 30 to 40% of patients with cancer actually have mood disorders. And that's not just what develops during the course of an illness, but what people bring into the illness. So depression and anxiety, which are rising in terms of the epidemiology in our society, PTSD that is pre-existing, and the PTSD, anxiety, and depression that may be a result not only of their disease, but of treatment. For example, PTSD is not that uncommon in patients who have had a prolonged stay in the ICU. So there is this interplay of what people bring with their mental health issues into having a serious illness, and the serious illness and its treatment can exacerbate those issues. We also help patients with grief, whether that's anticipatory or complicated or disenfranchised grief. And we help patients with complicated family dynamics, offering social support. And an area that I think is very exciting that both our fields kind of deal with is existential distress, treating it using psychedelics, which is an interesting field of inquiry that's common to both of our practices. And I also wanted to put up here the suffering of the teams. So at least in palliative care, and I'm sure in psych to a certain extent, when we're treating a patient, we're also treating the team, because sometimes the teams are the ones that need the support and the guidance and reassurance and handholding. So I'm going to skip over some of this because I actually do have a case that I'm going to take you guys through. So I'm going to give a couple brief examples of cases that I've had in the past where psychiatry and palliative care kind of united. So Mr. Lopez, these names are all changed, was 55 with a diagnosis of schizophrenia, and he'd been living off and on in group homes because of a history of violent outbursts. He's had a history of SI, but not made any attempts, and has metastatic pancreatic cancer, and told his oncologist that he doesn't want to get any more therapy. He was referred to us to see if he has decision-making capacity and to treat his symptoms of anorexia and abdominal pain. So for him, again, this determination of capacity for people with serious mental health illnesses, that becomes something that we are also commonly asked to weigh in on, especially when people are saying things like, I don't want treatment. And the teams worry that that may be an expression for this patient of suicidality, given his history. In our exam, he had full capacity for decision-making. And I think, again, sometimes helping people to understand that you can have a serious mental illness and have full decision-making capacity becomes a part of our conversations with teams and with patients. Oncology wanted further confirmation, so they did pull in our psychiatric colleagues. And there was some questions of how do you provide for good palliative care for people in a group home setting, where the group home is for folks with serious mental illness. So some of the issues we ran into were the prescription and administration of opiates in the group home setting, which was a big challenge. There was only one pharmacy that would dispense opiates to this particular group home and patient population. There was multiple forms of confirmation that I had to give to get the physician overseeing the group home and the pharmacy to actually release the medications that this patient needed. And again, this recurring theme of maybe he's going to, hoard his oxycodone and attempt suicide these issues kind of followed him everywhere. Just as an example of some of the bias that these patients face in getting the right palliative care. Ms. Barber was a 32-year-old woman with metastatic breast cancer who was seen by us for pain control. And unfortunately, we had a pain contract in place that she broke twice because she was using substances outside of the prescription substances that we were giving her. She was getting non-curative chemotherapy and had a lot of lower back pain and shoulder pain that was at times inconsistent with the imaging. And she was on about 800 oral morphine equivalents for pain control, frequently up titrating her breakthrough medications without oversight. And had refused fentanyl patches multiple times in the past. Tox screens showed both alcohol and unprescribed fentanyl. And so we had an interdisciplinary discussion, involving our mental health providers who had been seeing her. And there was a tremendous amount of concern for opiate misuse. But unfortunately, it was very hard for her and her partner to admit to it. And so she refused a referral to addiction medicine. This was another situation that was very challenging with a young woman with metastatic cancer who needed good pain control, but issues of substance use disorder really kind of got in the way of the teams feeling comfortable caring for her. And ultimately, there was also kind of a bit of leeway for her because she was young with metastatic cancer, so boundaries weren't really enforced, and that was something that our psychiatry colleagues had to weigh in on. We tried to put her on buprenorphine and then methadone and use a multidisciplinary approach to treatment, but unfortunately, this was not successful. And then Ms. Dunn was a patient who was pursuing what in California we call the End of Life Option Act. So physician-assisted dying, physician aid in dying. She was in her 60s with metastatic ovarian cancer and came in for pain control and delirium management. And we were consulted for both. And she and the primary team and the patient's husband wanted to pursue this act. At many hospitals, this was an outpatient procedure, but the inpatient team insisted that we do this inpatient. We found her not to have capacity for this decision, and her husband was unwilling to allow us to interview her alone. Psychiatry initially said she didn't have capacity, but under tremendous pressure from the inpatient team, were reconsulted and found in the next evaluation for the patient to have capacity. And she went through the process and took the medication to die on her own terms in a nursing home. This act, I know there's a version of it that is on the Massachusetts ballot. And I bring this case up because it was, again, a collaboration between palliative care and psychiatry, but psychiatry will probably have a significant role in this process. In California, psychiatry is not a mandatory part of the protocol, but at several institutions, including UCSF, where I trained, psychiatry is a mandatory part of assessing capacity and helping people through this process. So I want to shift gears just a little bit into the second part of the presentation, which is really about how do we talk about serious illness with our patients generally, but what is a specific case that I'm going to take you through and ask for some audience participation in, but how we would actually talk about these issues with patients. So in palliative medicine, communication is our procedure and words are our tools. And Dr. Susan Block, who was previously at Harvard, I think she's now at Duke, was one of the visionaries in our field who had said a family meeting is a procedure and it requires no less skill than performing an operation. Communication is really not formally taught in medicine, but it's essential to absolutely everything that we do. And when we think about how we talk to people, their goals, their treatment goals are kind of our lighthouse guiding treatment. And treatments that we offer should further those goals. And goals exist in a particular context, not a vacuum. And a part of the art of these conversations is drawing out the context, not saying what's important to you generally, but what's important to you given that, for example, you have gone through 5 types of cancer treatments, and at this point, your cancer is stronger than your body is. In that context, what's important to you? And sometimes the reason why goals conversations go awry or remain too theoretical is because drawing out the context can be a real challenge for us as physicians. The assessment of goals should be early, often, and ongoing. So again, from the time of a serious diagnosis, and kind of shifting from what do you want us to do for you, which is commonly how things are framed, not necessarily in those words, but in that way. And going from that to based on what you're telling me is important to you, here is what I recommend. There are different types of communication. So how many of you kind of have heard goals of care discussions and have wondered, like, what does that term actually mean, right? That term is very vague. It doesn't translate into most languages. And it's not really, when we say to families, we'd like to have a goals discussion, we have to be specific about what we mean. Right. So life-altering events, not just end-of-life care discussions, can result in new goals. So these were patients I had in my medical school training. A baker with worsening diabetes who is now on insulin and can't go back to his job. A woman who went under 4 cycles of IVF and suffered a pregnancy loss. A teenage basketball player who is diagnosed with hypertrophic cardiomyopathy and cannot play high-intensity sports anymore. Goals discussions happen whenever there's any sort of life-altering event, not just end of life. And there's a difference between medical updates and goals of care. So how many of you have been in meetings where a lot of information is given about what's going on, and then there's very, very long pause? Right? We've all been in that. Either we have done this ourselves, which I fully cop to my crimes of the past, or we're watching other people do this and it gets awkward and we're like, now what do we do? Where's this conversation going? So there's a difference between medical updates and actually getting into what the updates mean for the person before you and for their life. And then there's early conversations versus later ones, which we approach slightly differently. And the conversation guides, I'm going to take you through one of them. They're a starting point, but I think the art of these conversations is not just asking the questions, but knowing what to do with the answers that people give you. This is not a goals of care discussion, right? We're done when I say we're done. If a patient says this or if a doctor says this, sorry, I had to put a reference to Breaking Bad in here because I'm obsessed with it. But this is, I just wanted to remind everyone, this is not a goal. And this is also not something to say to people. So I'm going to take you through the case of Mr. Angel. Again, names change. This is a patient I had at my last job about 1.5 years ago, 2 years ago. He was a 58-year-old gentleman with a history of substance use disorder, cocaine and heroin, and major depressive disorder with 2 past suicide attempts. He's been on 40 milligrams of Prozac and 45 milligrams of methadone daily for the past 5 years as opiate replacement therapy. He sees a psychiatrist twice a month, and he's missed a number of appointments before he met his girlfriend. who he's been with for 3 years and who has a 20-year-old son from a prior marriage. 4 years ago, he was diagnosed with metastatic prostate cancer to the spine, liver, and lungs. And he's developed quite a lot of abdominal pain and bone pain, which we were treating with short-acting morphine and NSAIDs. But he was having a declining functional status and had to leave his job as a librarian very recently. His depression has been worsening since he had to leave his job. Before his diagnosis, he told us that his life was tolerable, but he was really struggling to find meaning and joy. He said things like, I hate not being able to get around independently. I don't want to take morphine, but if I don't, I can't do anything. My oncologist tells me to stay positive, but I feel like death will be a relief. I don't know what's going on with my cancer, to be honest with you. If I'd overdosed years ago, I wouldn't have to go through this. He doesn't have any active SI, doesn't have weapons in the home, and does not have a plan because he said he'd never tried since he met his girlfriend. So she was a real source of hope and light for him. But he also said he can't say he'd be devastated if he got hit by a car and died. So what are the major issues he's facing? And what are your concerns? Any pain control? Yes. Yep, absolutely. So hesitance to take pain meds based on how things may have been framed for him before. Grief? Yep, absolutely.
Meaninglessness.
Meaninglessness. Yeah.
Hopelessness.
Hopelessness. We have a lot of existential suffering here, right? Why did I get sober only to have this happen? You know, I can't say I'd be devastated if I got hit by a car and died. And these sorts of things can be very alarming for people to hear and to experience. He has these protective factors, right? He's got his girlfriend, and he is now regularly going to see his psychiatrist and taking his medication. So there are some things that he's saying certain things which need to be attended to, but his behavior is actually quite good in terms of going to his appointments and really relying on his sources of meaning and joy. And his fears about the future, fears of dying, of suffering. Sometimes when people have past psychiatric issues, any statement like this can be blown out of proportion, right? And they do need to be interrogated as if these are real important statements of potentially worsening depression. But I will tell you, I have a lot of patients without serious mental health issues who say these things. I can't, I'd be okay if a car hit me. And it's an expression of what they're going through, not necessarily an intent. But I point this out to kind of normalize that even when you have serious mental illness, helping other teams to understand that these expressions are also quite healthy, normal expressions sometimes of grief. And how you tease out what's what is part of the art of psychiatry and of palliative care. I think the other thing is he doesn't know much about his cancer, right? He doesn't know the prognosis. His oncologist is just telling him to be positive. So that was another thing that was an issue in his care. A lot of times, mental health providers have the longest relationships with patients. And you are well positioned to start some of these discussions. And so primary palliative care, which is a skill set that we try to teach all providers to have, mental health workers are actually very well positioned to take this on. So early goals of care discussions generally take place in a non-acute outpatient setting, ideally. What we want to do is understand what people know about their disease, their treatment options and prognosis, and understand their quality of life concerns. So their fears, their worries, their hopes, their sources of strength. We try to do advanced care planning, at the very least, identifying who's your designated proxy and have you thought about life support choices. And these things happen at different points in these outpatient or non-acute or early discussions. And advocating for better communication between patients and the provider who is managing their major life-limiting illness, and planting questions for consideration. Because when we lay that foundation, you have something to go back to, which, as you'll see in this case, became very important. So how I suggest doing this is, number one, normalizing the discussion, right? Kind of like we've learned to normalize screening for domestic violence. This is just something we ask everybody. So many people I care for are living with a serious illness, like breast cancer, that can worsen quickly. It is a part of my practice to discuss what that might look like and to hear from you what quality of life matters to you so I can help you make the right decisions for yourself moving forward. What has your oncologist told you about your illness? What are your most important goals if your health worsens? What are your biggest fears and worries when you think about the future or even the present with your health? What gives you strength? What abilities are so critical to your life that you can't imagine living without? If you become sicker, how much would you be willing to go through for the possibility of gaining more time? Given what I know about your goals and priorities, here's what I would recommend. And saying, we're in this together. Because I think sometimes I've seen that some of our patients feel abandoned by some of their other providers who may not know how to handle what they're going through. So really emphasizing that you're along for the ride goes a long way. And also normalizing the fact that the answers to these questions will change as the context of their illness and their life changes, and that that's okay too. So he knew his disease was stage 4. He didn't know that that meant that he could not be cured. He had gotten 4 different lines of treatment. At times he would say he wanted to know his prognosis. At times he said he didn't. His goals were to spend time with his girlfriend and her son, to try to improve functionally, and maybe even go back to his job at the library. He was scared of worsening pain. He didn't want to be a vegetable, which is, again, kind of a trash bag term that means different things to different people. He didn't want to be a burden. He was worried about running out of money and relapsing due to his use of morphine for pain control and becoming hopeless. His strengths were his girlfriend and his history of sobriety. And he was afraid of lingering, not necessarily dying. He just didn't want to be in this in-between liminal state that a lot of our patients with serious illness are in. He said he would dig up his gun and go out like a man. He doesn't have an advance directive, and he was not wanting to really discuss his wishes openly with his girlfriend. He thought she didn't know how bad the situation was. So what concerns do you have now, and what questions might you ask him?
Talk to him about maybe maximizing his pain control to prevent relapse. Try to destigmatize the issue that he's taking morphine. It's treatment medicine. And people with history of substance use, they don't necessarily, the data suggests they don't necessarily relapse if they're treated for their cancer or acute pain. The other thing I would try to definitely do is make him more accepting to the idea of bringing his girlfriend to the discussion.
Yeah.
Especially that she is the only support for him. Have her, and maybe with the oncologist, because there's also this issue, why isn't the oncologist being completely upfront with discussing this? The goals are clear and where he is right now. So those might be the first 2 things.
Absolutely. Super.
Yes, I agree as well. That was what I was going to point out, is it's really important to ask patients about preference of communication. And also in this case, it can be a detriment, especially when he's feeling like he might be a burden to his family if he doesn't have an advanced directive filled out. That can be problematic as well, both with how the family feels and how he might feel as he's progressing through treatment. So that'd be a concern of mine.
Absolutely. All right. So he started a 5th line of therapy, got 2 doses, and tried to reduce his use of morphine. He was, again, I think, really fixated on not wanting to use morphine. And he developed rigors, fevers, and sweats about a week later. And the covering outpatient ONC-NP was concerned that he was in withdrawal. So he resumed taking morphine. I think, again, that assumption that this is withdrawal, the lens through which we see people with serious illness who have other issues psychiatrically with addiction, something very big got missed, right? So 2 days later, he's in the ED with Klebsiella bacteremia. He's hypotensive and febrile. He got fluids and broad spectrum antibiotics, and his BP stabilized a bit. It was likely urosepsis. And the resident called palliative care because he was expressing a desire to be DNR, but was worried that this was an expression of suicidality, given his past. So again, looking at somebody through a specific lens that doesn't really allow for the full expression of his choices or explanation of his choices, or in essence of his full humanity, right? And the team attending said that he has treatable problems right now. So it kind of didn't get into any sort of oncologic issues. And in the chart, they had documented that the patient said, just let me go, and insisted on changing code status. So I don't want to be a broken record, but I think this is something that is just so important. The bias and the lens through which we see people, the concern for withdrawal, number one, right? Which was a little misplaced given that he had a lot of other stuff going on. A life-threatening infection in the wake of new cancer medication. He's got a change in code status that was misinterpreted as evidence of passive SI. Further exploration of these choices wasn't really attempted. We were just kind of consulted. In questioning capacity, does he have the ability, given his issues, to make his own choices? And how would these scenarios be totally different if someone did not have a history of serious mental illness? So in our consultation, he didn't know the updates about his condition, the reason for the bacteremia or the state of cancer on his CT. Didn't really know the intention of his cancer treatment. Again, he thought he was curative, or his prognosis. He didn't want to hear a lot of bad news. Again, said, I don't want to fill out an advance directive or have a family meeting. And he was maybe mostly concerned that his girlfriend felt that he wasn't misusing morphine. And he wanted, again, to go back to work ASAP. He said, I know what CPR is and I don't want it, but if you put me on a ventilator, if you need to, that's okay for a few days. He didn't want long-term ventilation. And we talked about reversible versus irreversible causes of intubation. What would result in prolonged intubation in this situation, and what would be a short-term use of the vent? To, again, make sure that his consent was fully informed, that he really knew what he was committing to if we intubated him. And he continued to have fevers. And then he decompensated. So his BP dropped to 70 systolic, unresponsive to fluid. He had a lactate of 9, came in at basically a lactate of 1, went to 9 very quickly, increased work of breathing, went to the unit on a non-rebreather and had to get pressors started. And very quickly went from a non-rebreather to high flow nasal cannula at 40 liters and 50% FiO2. Antibiotic coverage was broadened, and we now see on CT that he has a perirenal abscess and a submassive PE. So the ICU called the girlfriend who came in with her son. So when we think about a family meeting, the biggest thing I want to say here is thinking about the 2, maximum 3 big points that you want the patient and the family to hear and understand. And putting what's happening acutely into the 30,000-foot view of the landscape of someone's illness or illnesses. I always tell teams, try not to start by asking for the family's questions, because that can get things off track pretty quickly. Don't assume that everyone's gotten accurate updates, and avoid very long descriptions of pathophysiology, labs, and imaging. I generally do not, again, advise offering interventions like, do you want us to do X, Y, and Z? But consider the interventions that are reasonable to offer based on their condition and their articulated goals. So I have some very text-heavy slides coming up, but wanted to give you some language. So what I'm hoping we can do over the next 30 minutes is discuss Mr. Angel's condition, answer questions that you might have. Oh, this is like in the family meeting. Yes, I am definitely running short on time, and I apologize for that. I want to kind of emphasize these last 2 points. I want to be sure we all have the same information about what's going on for him. Can you tell me your understanding of why he's so sick? And then concisely describing what's going on for him. He came to the ICU because he has a serious infection that started in his bladder and spread into his blood and around one of his kidneys. He also has a large blood clot in his lung, causing strain on his heart. We are using powerful antibiotics, high levels of oxygen, and blood pressure medicines that we can only give in the ICU to buy time and to see if he will recover from this infection. And in the context of everything else, right, anyone at baseline who develops an infection like this and needs to come to the ICU is in a very serious condition. But what makes this especially concerning is that his body has been weakened by the cancer and its treatments. And he's more prone to serious infections and blood clots, and he will also have a harder time fighting both of them off. So you want to help people understand in a concise way the relationship between the acute decompensation and the bigger picture of his illness. Being very clear about what constitutes recovery, right? So saying things like, we'll do these things and see if he gets better is not being precise, right? Because to a family member, an improved creatinine is getting better. So we want to talk to them like we talk to each other on rounds. He's on 2 forms of life support. Over the next few days, we want to see him need less and less oxygen and blood pressure medicines, because the less we do for him, the more his body is doing for himself. And that's the sign of recovery. And saying what constitutes a setback. So if he becomes sicker, that would mean he needs more and more oxygen support and more blood pressure medicines. And that means that his body is struggling to maintain itself without more of us intervening. That is a bad sign. And then asking if he ever had any previously expressed wishes, and quality of life questions. What's a good day for him? What was a bad day before he came in here? And what do you think he would say if he were listening to this talk? So I try to invite the person into the room. So the surrogate is not thinking it's all on them, but you're asking them to channel the voice of the person they love. She expressed a hope for a full recovery. She knew the cancer was bad. And she also said, I know he was trying to protect me, but I know more than he thinks I do. The oncologist said once he's stronger, he can get more chemo. Do you think he has a chance of getting better? He's a fighter, has always told me he wants everything you can do to help, him, not her, live. I'm a Christian, and I know God's going to pull off a miracle. And the girlfriend's son reiterated, please do everything possible for him. So examining the words we use, right? There is still hope. She's a fighter. I will do everything possible. Hope, miracle, fighter, everything stable, prognosis, treatable, better, saving a life, passing. These words are pretty unintelligible, right? What do they actually mean? And when someone's using them, what do they actually mean? That's the art of getting into these conversations more deeply. To go a little quickly through the rest of this, he was able to come out of the ICU, but then he actually had a massive aspiration event and was peri-arrest, came back to the unit on more high flow and more pressors. And because he'd also been a little altered at times and had some dizziness when he came to the floor, They did a head CT with contrast and found multiple brain mets. So the other thing I try to help people understand is we recite a lot of facts in these meetings, right? But we want to express the significance of the facts. What do these updates or changes mean for him? It's not just that he has new brain mets or just that he now aspirated and is back in the ICU. What that means is that he is now much closer to dying from his illness and that the fifth line of treatment is not working. So what will that mean for the end of his life? And really thinking about when we're explaining the technologies we're using, a ventilator is a ventilator, right? What it means to be on a ventilator when you have had a car accident versus when you're waiting for a liver transplant versus when you have metastatic cancer, it's different, right? The significance of a ventilator is different in each of those circumstances. And that's what we think people get, but I've learned we have to be very explicit about what it means. So again, asking, tell me what you know at this point, and being very concise with the update. He came back to the ICU because he vomited food that got into his lungs. This happened because the cancer, we have learned, has spread into his brain and affected his ability to swallow food. It's also caused his dizziness and confusion, and he needs even more life support now than he did a few days ago. Because the cancer has now spread into his brain, unfortunately, we have no more treatments to offer for the cancer. And trying to help people understand that there is a way that the body shows us its limits. And when we're so used to medicalizing the body and talking about manipulating it with technologies, we kind of lose sight of the fact that nature will always win over medicine at a certain point. And that what it means to recognize that and reckon with it is part of what we have to help our families to do, but we have to be okay doing that too. So during this hospital stay, he's needed life support twice that we can only provide in the ICU. He has infections, blood clots, and an inability to swallow. And all of this has happened because his cancer has weakened his body's ability to fight infections. I want to share with you that when people suffer from complications like these, it's because the cancer is becoming stronger than their bodies. And really thinking about how we get into the statements of fighter, wanting a miracle, wanting everything done. These words mean very different things depending on the context and the person using them. What does doing everything mean? And I will ask people, help me understand what everything looks like to you. What if everything is being done and his body is still showing us that it's dying? Tell me what you are hoping for when you want a miracle. When you tell me that you're a fighter, can you help me understand what that means to you? How is that different now than maybe at the time of your diagnosis? What if we approach these terms with curiosity, we can get definitions that are maybe not what the person wants, but something that they can more reasonably hope for? Can we reframe expectations by first going deeply into these words and helping people tell us what they really mean? And again, talking about the body's limits and nature's limits, especially in situations where how many of us have been in conversations where oncology says, or whoever says, if you get stronger, we can give you more treatment, right? What does stronger mean? And when we put that onto a person, if you get stronger, we can treat you. That's an immense amount of pressure. So distinguishing between the person as a fighter and the body as an entity that may not be able to fight, a person with strength of spirit, but a body that is not strong enough to take on the assault of the disease, that distinction can help people understand that it's not about willpower. It's not about fighting to live or giving up, quote unquote. Those binaries don't make any sense and can be very disempowering. So we actually got his psychiatrist to join the next conversation and looped back to some of the things that his psychiatrist and us had talked about. He wanted to go back to work, right? He didn't want to be dependent on people. He didn't want to linger. And so bringing that back into the conversation was a huge part of how we were able to advance the discussion. So his girlfriend was able to come to terms with both what she knew and what he had talked about before. We weaned down his pressors, but he stayed on high flow and eventually transitioned him to comfort care, and he died with his girlfriend by his side. So there's a lot of overlap between our specialties. There's a lot of importance of mental health providers being that continuity of care for patients with serious illness. And our collaboration can help to close the gap in the disparities that people with serious mental illness face when they have serious other illnesses. I know I'm right up against time, but thank you so much. And if there's questions, I'd love to take them. And maybe.
I think in the interest of time, I'm going to let people come up to you and ask you privately. But thank you so much. This was very interesting. And you know, we're actually starting a psilocybin study for treatment-resistant depression, but the first use of it was in end of life at Hopkins, I think that, and so it was an important study. Thank you so much.
Thank you, guys. Sorry for not having time for questions.